Advanced Patient Care Theory 2, Unit 4, Part 1b, and let's talk about hyperglycemia. A couple of people have an open mic, FYI. Right. Okay, so we'll talk about hyperglycemia and its sort of briefly on its patho and clinical presentation, and then we'll talk about management of hyperglycemia. So most diabetic emergencies you and I see, of course, as you know, are hypoglycemic patients, and on rare occasions we see hyperglycemia. Just out of curiosity, how many of you have actually had a patient, not just hyperglycemic with a higher than normal blood sugar reading, but a true diabetic ketoacidosis? Okay. Multiple, Charles? Must be. Is there a higher incidence of diabetes in the region where you work? Okay. Now, is that because you service a lot of the native communities?
Sorry, I'm just typing was taking too long. We just have a lot of chronic disease. I think maybe Roger's there, maybe he can comment, but I think the demographic and the fact that we had a lot of people that got their grade 10 and then started doing high paying jobs. They tended to make poor life choices over a long period of time that then by the time they hit 60 start to catch up to them. So we have a lot of diabetes, a lot of COPD, and a lot of CHF here.
Yeah, so it sounds like you have a lot of type 2 diabetes, but like,
Oh yes, of course,
so
yeah,
because
yeah.
a true diabetic ketoacidosis we see in type 1 diabetics, we don't see that in type 2s. So,
No, you're right, you're right. But I have seen a lot of it. Maybe it's just chance, or maybe it's demographics.
yeah, okay. Okay, interesting. Um, all right, so diabetic ketoacidosis, as I said, takes place in type 1 diabetics, and either because patients are not taking their insulin or they're eating more than they should be. But most often we see diabetic ketoacidosis in patients who have developed an illness of some sort, of flu, fever, and have been ill for a few days or so. We see it progress over the course of about a week. It's not typically acute like we see in hypoglycemia. The other one is hyperosmolar hyperglycemic non-ketotic coma, or HHNK. And we see this in type 2 diabetics, although I don't think I've ever encountered a true HHNK. I've encountered a couple of type 2 diabetics who are hypoglycemic, which is a little unusual for type 2s, but not a true HHNK. Out of curiosity, has anyone here had a patient with HHNK? No? Okay. Yeah, and I'm not sure what the incidence of it, but presumably it's fairly rare. Um, so let's talk a little bit about diabetes in general. What we see in diabetes in general are the three P's. That's usually when the diagnosis is made, when someone complains of excessive peeing and excessive thirst and excessive hunger, and that's usually when they go in to see their family physician, and it's discovered that they're diabetic. In type 2 diabetics, you could probably add a fourth P, um, and that would be polyuria, polydipsia, polyphagia, and polygrip, since it happens in older patients. Ha 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 ha. And sorry, I kill myself sometimes. What we also see with diabetics early onset is dehydration. Thanks, MJ. And general weakness, lethargy, altered LOA, nausea, vomiting, abdominal pain, hypotension with reflex tachycardia, fruity breath with DKA specifically, and Kussmaul's respiration. in DKA. My the last DKA patient I had was kind of interesting. We got the call as a potential psych patient. He was 22 or 23-year-old who, and this was about 6:30 in the morning, and he was attracting a bit of a crowd. He was naked in the elevator and was shouting and just writhing on the floor, and police were there and they called us and we got there, and as soon as I touched his skin he was hot, 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 and that's classic in hyperglycemic patients, hot and dry. And we tried to get a history but couldn't get one, and got him out of the elevator and onto the stretcher, and we took his blood sugar just red high. And for early management, the best thing you can do is rehydrate them. So get an IV in place. I patched to my base hospital doc because he didn't meet the criteria for a fluid bolus, and the doc gave me said give him 20 cc's per kilo over an hour. And of course, when he said that, I knew it was going to be maybe 20 minutes before getting to the hospital from the time we get him into the vehicle and to triage. But I'm not going to say, we'll be there in 15 minutes. I'm just going to run it accordingly. So we got about 800 mLs into him, and he was much, much better just with a little bit of rehydration. In hospital, they'll give him insulin, but it's remarkable how a little bit of rehydration really makes a difference. He was stopped shouting, he stopped sort of thrashing around, and just settled right down after we gave him some fluids. So you can be in DKA with blood sugars as low as 8, 9, 10. And we see this in kids, but generally speaking, with adults, you and I typically encounter a full-blown hyperglycemic DKA with Kussmaul's with blood sugar levels that are reading high, so 33 or above. But just know that diabetic ketoacidosis can happen with much lower blood sugar levels. Now, it's normal to expect high blood sugar levels in non-diabetics after trauma, after seizures, after any sort of fight or flight response. That's a normal finding. So the differential diagnosis for hyperglycemia is, of course, hyperglycemia, methanol intoxication, lactic acidosis, so renal dialysis patients, starvation acidosis, salicylate overdose, hyperosmolar hyperglycemic non-ketotic coma. Oops. Here. And the management, at least from a field perspective, is obviously ABCs. And if you need to protect the airway, NPA is probably a better choice because their airway is probably going to improve over time. So just remember, if there's a reversible cause of an airway issue, we try to forego intubation and address the underlying issue, which can be hyperkalemia, hyperglycemia, hypoglycemia, hypoxia, volume depletion, etc. So intubation generally we'll hold off on, but SpO2 and room air, O2, ECG. Now, just a question. You've got, let's say, a diabetic ketoacidosis patient. Is it possible to have some sort of abnormal SpO2 reading in a patient who's otherwise got a good respiratory rate and volume, even Kussmaul's respiration? Is it possible to have an abnormal SpO2 reading, and why?
Can you have an abnormal reading from the pH shift?
Yeah, so explain that further.
So if they're acidotic, it's going to affect their oxygen dissociation curve.
Yep.
So they're going to be acidotic, so they're not going to hold on to oxygen as well.
Yeah, exactly right.
Yeah.
So they may have a low SpO2, and it's not unreasonable to, for that reason, to give them oxygen via NRB, which we did for this guy who was diabetic ketoacidosis, because their hemoglobin's doesn't pick up oxygen as readily, so we can provide supplemental O2 to increase the oxygen saturation and increase the amount of oxygen dissolved in blood plasma. Good. Yeah, excellent. So glucometry readings, typically when they hit about 33 millimoles per liter, will just register high with most pre-hospital glucometers. So we need an IV access, ideally a large bore IV. We can give fluids for hypotension. Certainly, we just follow the medical directives. Otherwise, we should be patching for fluids for these patients. And in terms of kids, recommended that we patch for IV fluid bolus in kids between the age of 2 and 11. For suspected DKA. Gestational diabetes. So this, as we talked about before, develops during pregnancy, and hormonal changes create insulin resistance, and that body causes the body to increase insulin production. And if the pancreas can't keep pace, then high blood glucose results. And for most women, once the baby is born, the gestational diabetes disappears. But there's a higher risk of developing type 2 diabetes in pregnant women who have gestational diabetes. I know that was the case with one of my sisters. And so insulins, I'm not going to go through these. You should be familiar with the common insulins, but I would just review this at your leisure. But what I would say is, just a reminder that when you're looking at a patient's meds, if they give you a med list, I find, well, particularly if they give you a blister pack with their med list, you won't see things on there like their puffers and their insulins. So, it's, if you take a blister pack with you, don't forget to ask about whether they're on puffers and whether they're on insulin, and then find out what insulins they're on, and what doses they take and what time of day, and so on and so forth. Someone's going to say something?
Yeah, I was just going to mention with insulin, I don't know if it's here, but I find a lot of people are really poorly informed about how insulin works. I've gotten like a million calls where they're hypoglycemic and they've taken their extra insulin thinking it's supposed to help with their blood sugar. I don't know if anyone else has experienced that anywhere else, but it seems like I've done at least 3 or 4 of those cases here.
Yeah, that's interesting. I haven't personally, but that's interesting. Anyone else? Okay, you're just a shit magnet then.
As I say, it must be unique to North Bay.
Probably not, but yeah, calls are funny, eh? It seems like everyone has their niche of calls. That might be your niche. Mine seems to be patients in continuing seizures and SVTs. Those are my 2 most frequent ALS calls.
Yeah, keep those.
Yeah. I can keep those? You don't want those? Those are good ones.
Yeah, no, I'll keep my...
I love hyperglycemic patients. They're the best. Okay, so pheochromocytoma. This is... I've never encountered a pheochromocytoma. I know a PCP crew who encountered a pheochromocytoma while I was a base hospital program manager, and it was an interesting case. So, as you know, it's a rare catecholamine-secreting tumor on the adrenal gland, and so when you've got hypertensive patients, it's something to consider. And so it occurs in about 0.05 to 0.2% of hypertensive individuals. And clinically, though, they don't typically present hypoglycemic. Typically, they present either with a hypertensive event or hypertensive event-like symptoms like headache, altered LOC. They have intermittent bouts of fight or flight responses, so they get diaphoretic, they have palpitations, they have tremors, nausea, weakness, anxiety, a sense of doom. Because you think about it, they're having these catecholamine releases, right? So their vital signs tend to be labile, meaning their heart rate goes up, then it comes back to normal. Then it goes up for, minutes to hours, then it comes down. Blood pressure goes up, then it comes down. And they're more likely to be hyperglycemic, but if over time their metabolic demands just are higher than their body's ability to continue to regulate glucose, then they become hypoglycemic. So just know that it's unlikely you're going to encounter a pheochromocytoma with hypoglycemia. But if you do, listen carefully to the history. If they're not a diabetic, especially, and they give you a history of these feelings of doom, feeling of flush, feeling, the heart's racing, that sort of thing, then there may be there's a potential for pheochromocytoma. And the one case I know of, so only one case I know of personally, was a PCP crew who had a patient like this who said he was being investigated for pheochromocytoma. So they held off on giving him glucagon because they weren't IV certified and they weren't giving D50 at that time. So obviously your best bet is always to give D50 if you suspect pheochromocytoma as the cause of hypoglycemia. But so that was. Has anyone here encountered a patient with pheochromocytoma?
Yeah, I found one once.
Yeah. Oh, do you want to tell us about it?
It was a number of years ago, and it was something completely unrelated.
Okay.
And it was just in their history list, and they were very well informed about what it does and how it works.
Okay, interesting.
Very, very quick to point out that glucagon would make them very sick.
Yeah. Were they diabetic as well?
No, actually they weren't.
Oh, okay. Yeah, so that's
relatively young guy as well.
Oh, okay. Okay. Yeah, and that, if you encounter hypoglycemia in a non-diabetic, that's a little unusual, and that should raise your index of suspicion that there's something else going on. Now, the one thing that is not mentioned in the medical directives as a contraindication or even a relative contraindication, but is considered in most texts as a relative contraindication is to glucagon, that is insulinoma. D50 not an issue, right? And that's good that PCPs across our province are slowly starting to get IV certified and can give D50. So insulinoma is a neuroendocrine tumor, and mostly in the islet cells, found in the islet cells in the pancreas, and the result is that they produce excess amounts of insulin, and the patient could consequently become hypoglycemic. And again, this if you've got a non-diabetic who's hypoglycemic and confused, then this is one of the things you have to think about. So about 90% of insulinomas are benign, and they have episodic hypoglycemia, and the usual clinical manifestations associated with hypoglycemia. And D50 works effectively. I saw a patient in the eMERGE with, it wasn't my patient, but I saw a patient in the eMERGE with insulinoma who had to get 2 bolus of a D50 and then had to be put on a glucose drip, or I can't remember what the concentration was, but it was a higher than normal dextrose level. I think they might have put a couple of amps into a bag and infused it over time because his blood sugar just kept dropping continuously. So in the text, in the pharmacology text, glucagon, I've only seen it listed as a contraindication to glucagon once, but in most texts it's listed as a relative contraindication. So just know that if you went ahead and gave glucagon to an insulinoma, it might correct their blood sugar, it might actually worsen it. So that's a potential risk, but it's not listed as a contraindication in your medical directive, so no one can criticize you for giving it. But again, this is, in my view, one of the shortcomings of the medical directives is they don't list all of the contraindications, and some of the things they list as contraindications are not true contraindications, they're more like conditions. Okay, so here's a question for you. Who discovered insulin? And by the way, I created this multiple choice question long before Trump was elected president. Going once, going twice. Okay, getting D's for answers. And the answer is, yep, Sir Frederick Banting. And anyone know where he was born? Okay, most people are answering C, and the answer is Alliston, Ontario. Yep, excellent. Excellent. Any questions about diabetic ketoacidosis or HHNK?